Alright guys, my name is John, and today's topic will be blood occlusion training. Blood occlusion training is simply the restricting of the venous blood to the muscle. It's beneficial. It's a plausible exercise program to increase hypertrophy and strength, hypertrophy. It's simply basically restricting the vein and causing the blood to pool into the muscle. And you can accomplish this by using a cup or a pressure cuff, or a wrap. So why use blood restriction training? It allows the person to use a lighter weight to still achieve a sizable anabolic response. So you can train at loads light as 20% of your 1RM and still you get an increase in hypertrophy and strength. It's especially useful for patients that are injured or are trying to go down from heavy weights to their joints, ligaments, and tendons. It can give them a nice break from doing it. So in order to understand how it works, you have to understand the three types of fibers of which people have. Slow twitch fibers, which are slower contracting rates and have low fatigue and are highly anaerobic. So when you think of slow twitch fibers, you want to think of marathon runners. Type 2As or intermediates, they're somewhere in between. They're faster contraction rates, but they have short bursts of speed and strength, and they use both anaerobic and aerobic fuel sources. So slow twitch, like I said, anaerobic is using oxygen as its ATP production. And then type 2X, which is fast twitch fibers, have the highest constant contraction rate and highest fatigue rate. So they're quick, powerful bursts of speed, but they do anaerobic energy sources like phosphocreatine. Okay, so the way it works is fast twitch type 2 are recruited last, normally during contractions, and are highly anaerobic. So while slow twitch requires oxygen and are recruited first, but blood restriction training causes your slow twitch muscles to pre-fatigue and force your fast twitch muscles to handle the load. So basically, you're forcing your muscles to take over the load of what normally would be done by your slow twitch fibers. It produces the same metabolic response as lifting a heavy weight at a low load. And it changes in muscle fiber types from slow twitch to fast, increases the potential for growth and strength gains. So what the changes that occur in the body, muscular hypertrophy, so the increase in size of muscle cell components, but not actually fiber dysplasia, or fibers, which is dysplasia. There's no actual evidence that humans really go through dysplasia, but necessarily they increase the density of their fibers. It also increases the growth hormone concentrations of up to 2 times greater than what you would have from a normal heavy resistance training program. So you also get an increase of hormone production than what would you normally see. Shown to increase muscle protein synthesis, mTOR signaling, which helps in protein synthesis and transcription processing. And the expression of NOS1, which has been shown to increase muscle growth and increase in satellite cell activation. And satellite cells are basically almost like inactive nucleuses that will aid in transcription and repairing the muscles as they need to be. They'll take over, especially in this process. And there also is a reduction in myostatin concentrations, which are an inhibitor of muscle growth. So it's basically what tells your cells to stop growing and increasing their size. Okay, so and another thing that's noted when you do this is it's reversed from traditional adaptations. So normally when you do an exercise program, you'll have a traditional 4 to 6 weeks as the greatest gains that you see are all neurological adaptations to your body. Signaling's done better, and then 6 weeks after, muscular hypertrophy is the main reason you get strength gains. But with occlusion training, it's actually flipped. So normally you get the neurological adaptations first, but with this, in the first 4 to 6 weeks, you actually gain hypertrophy first, and then it comes into neurologic adaptations later on. And if you look at the chart, you can see like normal strength gains right here, go straight into it, and then you see neural adaptations will come in slightly later for LIBFR, which is the resistance one, as in the strength gains will come in above it. Okay, so an average workout routine that you could find for resistance or for a blood occlusion would be frequency following the FIT principle. This is an average one that you could find 3 to 5 days a week within at least 48 hours rest in between each muscle group, so enough time to recover and heal. Intensity is in between 20 and 30% of your 1 rep max. You can do lower loads and still achieve the higher strength gains. So the time is basically 10 to 25 reps within a 30-second interval rest in between each set. So So it increases the blood flow into the muscle and anabolic production. And you're going to do 2 to 5 sets per muscle group. And anywhere between 2 and 8 exercises that focus on major muscle groups of the body. All right, and I looked at a meta-analysis that talked about if cuff pressure is actually a determining factor to see if it makes a difference. But they did different pressure tests at lower levels and high levels, and there was actually no difference. And they even did a test to see if you can slowly increase it as you go along to go with it and adapt, but that doesn't make a significant difference either. So as long as the blood's properly concluded, it doesn't matter what pressure is done, as long as it's done safely.
Do you know what the minimal, like what the range was?
I think it said anywhere between 100 millimeters of mercury and 130, or 150. And they said the optimal is about 130 millimeters of mercury, but I mean, I read multiple tests that they done in between. They did up as high as 220 millimeters of mercury and low as like 100. So it just has to be enough to conclude the thing. So in conclusion, it's a valid method of hypertrophy and strength training. It's gentle on the joints and can be beneficial to people with injuries or limitations. It's a very intense method of training though, so it cannot necessarily be done on some people that aren't like willing to go the way. So basically it's as if you were like to sit on your arm and then try to lift with it. So it's a very intense feeling and sensation. So being able to get through it may be specific to the population that you can perform it on. But overall, it is a very valid method and has seen to increase plenty of gains in strength and hypertrophy. Are there any questions?
Did you come across anything about like damage to the veins or the venous system?
I did not. As far as I saw, it didn't say that it causes any damage to it. They didn't say that it had any negative effects. I even looked into it with people with certain diseases, as long as the severity isn't bad. Even with PAWS or PAD, they recommend it lower, obviously because it's not necessarily getting it all the way through already. But they said it can even be done with most patients. So they didn't have any damage done from what I could read.
Sometimes I look at my veins and I'm like, oh my god, they're gonna burst.
They're gonna burst sitting there.
Yeah, I mean, I know some of the stuff I've read so far, like some of the contraindications, usually people with blood pressure issues, any kind of history of like DVTs, that kind of stuff tends to be contraindicated. It's not like they're not necessarily absolute contraindications, but they tend to be like used with precaution. So
Yeah.
But I know that's why I was wondering about the minimal, like what's the minimal, because we've done it and it is very uncomfortable and a lot of our patients probably won't tolerate it, but is there a minimally effective dose? If you could go like 50 millimeters mercury at the same effect, some people could tolerate that versus 100. 100 is enough to get uncomfortable.
Yeah.
That's why I was wondering if you, once you read it, any minimal.
As far as I read,
it's got to be a certain amount of to be effective.
One of the essays I looked into was a meta-analysis that compared I think 4 or 5 different tests done over month periods, and they even looked at one for cardio and different things. But overall, they didn't have the distinct number. In fact, one of the main points they made in one of the analysis was as long as it was properly secluded to the point that it was pretty much close to majority of it concluded, and then only 20% of arterial would be concluded, as long as it doesn't go more than 20 for artery. That's what they're saying. Anybody else? All right.
Yeah.
And those are some citations.